Welcome to our CME and SDMS CME accredited ultrasound webinar, Cardiac Demonstrations from Start to Finish, How to Prepare and Optimize Your Bubbles in Your Machines for Echo. My name is Matt Wilson, representing the International Contrast Ultrasound Society, ICUS, in collaboration with Northwest Imaging Forums, the CME provider for this program. Northwest Imaging Forums is accredited as a CME provider by the ACCME. Northwest Imaging Forums designates a CME activity for one Category 1 credit towards the Physician's Recognition Award of the American Medical Association. Sonographer SDMS CME is also provided for those wishing to receive up to 1 hour of credit Category AE. All disclosures are listed on the second slide of the faculty's respective presentations and will be read verbally to you as well. Regardless of any commercial relationships that may exist, please be aware that as an accredited CME activity, scientific rigor, fair balance, and avoidance of any commercial bias are goals of this webinar. Any relevant financial relationships have been mitigated by Northwest Imaging Forums. The planner has nothing to disclose. Please find the Q&A button on your screen's lower menu bar to readily ask questions of the faculty as you are listening to the respective presentations. They will respond to questions in the live Q&A period towards the middle of our time allotted. I would now like to hand it over to Dr. Steve Feinstein for updates and opening comments. Dr. Feinstein.
Hello and welcome. I'm Steve Feinstein, the co-president of the International Contrast Ultrasound Society. I'm pleased to present today's seminar, Cardiac Demonstrations from Start to Finish, How to Prepare and Optimize Your Bubbles and Your Machines for Echo. The wonderful faculty includes Jordan Strom, Jessica Stout, Christine Merrill. And this is a free educational seminar presented by the International Contrast Ultrasound Society in coordination with Northwest Imaging Forums, our CME provider. Again, welcome to all of you. This is the first of 2 new programs showing how to prepare 3 ultrasound enhancing agents and how to optimize ultrasound equipment and software. We focus today on cardiac applications, and then October 30th, we will focus on liver and kidney imaging. The esteemed faculty today includes Jordan Strom, Jessica Stout, and Christine Merrill. And to our friends at Northwest Imaging Forums, they provide the exclusive CME for the ICUS seminars. And to each of you for your interest in today's webinar. Again, please visit our website at www.icus-society.org and see our remaining 2025 webinars. On behalf of the ICUS and Stephanie Wilson, my co-president, I begin. What is ICUS? Well, it's the only global professional society solely focused on CEUS. We are now in 85 countries, physicians, sonographers, nurses, scientists, industry, and patients. Many disciplines, radiology, cardiology, hepatology, vascular and GI medicine, and many more. What's our commitment? It's to CEUS education. This is for physicians, sonographers, nurses, and other allied professionals. Check our calendars on our website for registration. All webinars are recorded and available on the ICUS website and the mobile app. CEUS is an essential tool for modern ultrasound labs because it's safe, reliable, versatile, patient-friendly, and, of course, cost-effective. CEUS provides very high resolution, real-time images of the cardiac system, major blood vessels, and organ and tumor perfusion. CEUS often reduces downstream testing, it improves hospital workflow, and speeds access to diagnosis and therapy. Please explore the website. It is the most comprehensive suite of contrast-enhanced ultrasound resources available. Our mobile app is free. Please connect, try the Apple or the Android QR code, and follow us on our CEUS News Monitor. There's Bubble News, trends, conferences, calls for abstracts, links to virtual exhibits by our sponsors, and on the website, Sonographer Training Resource Hub. It's scalable, plug-and-play modules for sonographer training curricula, links to product labels, webinars, reference materials, and developed by a joint task force consisting of AIUM, ARDMS, ASE, ICUS, IAC, SDMS, and the updates are pending. Okay, so IV training and certification, part 1 and then part 2, and then there's a pending section. Part 1, IV training webinars with free CME, see our website. Part 2, hands-on IV training offered by Northwest Imaging Forums and promoted by ICUS. And finally, pending IV certification offered jointly by ICUS and Intelios ARDMS. And please have your colleagues join ICUS and join the conversation. It is with great appreciation that we honor our sponsors for their generous support of ICUS and their leadership in the field of ultrasound. This includes at the diamond level, Bracco, platinum, GE Healthcare, gold, Lantheus, silver, Canon, Siemens, and Sonoscape, and bronze, Denton, Fat Roman Studios, Northwest Imaging Forums. Today's agenda is listed. We will go from better to best to how do we get great images, to demonstrations, live question and answers, demonstration, wrap-up comments, and we will conclude. It is now with great pleasure I have the privilege to introduce our first speaker, Jordan Strom. He is a member of the ICUS Board of Directors and Secretary of ICUS, Associate Professor of Medicine at Harvard Medical School, and he is the director of the Echocardiographic Laboratory at Beth Israel Deaconess Medical Center in Boston. Thank you all again for joining. Thank you.
Hello, my name is Jordan Strom. I'm director of the Echocardiography Laboratory and a cardiologist at Beth Israel Deaconess Medical Center in Boston, Massachusetts, an associate professor of medicine at Harvard Medical School. I'm also secretary of the International Contrast Ultrasound Society, and it's my pleasure today to talk to you about the basics of contrast ultrasound for cardiac application. Here are my disclosures. One of the important disclosures is that UEAs, as we call them in cardiology, to distinguish them from iodinated contrast, have a lot of uses other than the one approved use, which is left ventricular opacification. But we will talk about many of the uses for this. Now, I think it's important to bring up the idea of harmonic imaging, because this is really fundamental to what we do within our practice to be able to image. Traditional imaging is fundamental imaging, and that in that the ultrasound frequency that's transmitted is ultimately the one that's received. So you send out a 1.6 megahertz probe pulse, you get a 1.6 megahertz pulse back. But we know that every tissue has a resonant frequency, and this is a physical property. Transmission at that frequency ultimately causes oscillations of the structure at frequencies at multiples of the transmitted frequency, 2 times, 3 times, etc. So you can take a 1.6 megahertz pulse, and ultimately you can get a signal back at 1.6 megahertz, but also at 3.2 megahertz and then some. And we can exploit that to listen for those harmonic signals to improve spatial resolution. And just to put this into a context of normal daily activities, this is in fact what we call overtones on a guitar. If you strum a guitar, some part of the guitar resonates, and that creates some of the smaller portions of the string, and that creates these overtones, these harmonic frequencies that make a guitar sound different than a piano. Similarly speaking, if you go to the opera and you have the opera singer sing a very high pitch, and that causes glass to break, and that's because the pitch or the frequency at which the opera singer is singing, it actually matches that of the glass and causes the glass to oscillate, which can't withstand the structural deformation. So harmonic imaging is really greatest at the depth of where we use it for echocardiography, with about 10 to 20 centimeters from the transducer surface. So this is really helpful to not only improve our imaging of bubbles, but it's also helpful to improve our imaging overall, which is why harmonics is our standard preset, or second harmonic imaging is our standard preset on most echocardiography machines. And in the near field, there's very little harmonics that are produced, and in the far field, the harmonic are attenuated faster than they're produced. So that middle is the sweet spot. And what we see is we see a couple of peaks. We see a subharmonic that's below the fundamental frequency, but we also see a second harmonic, a third harmonic, etc. And one of the nice part about these bubbles is not only do they have a nice property and ring at these second harmonic frequencies, but they also have nonlinear effects. They compress or they expand more than they compress, and that causes a nonlinear signal, which ultimately we can pick up on selectively to be able to bring out the image. And at very low MI settings, where the ultrasound power is very low, below particularly 0.2, but even less than that, we have very little activity from the tissue itself, and we get very little signal from the tissue, but we get a nice harmonic signal from the bubbles themselves, and that allows us to be able to create this effective tissue contrast. And in particular, we're able to really focus on the activity and the motion of and the appearance of these bubbles. It also allows us to be able to keep the bubbles in circulation for a longer period of time. Now, why might you want a little bit of a higher MI? And there's one circumstance where this is particularly the case, and this is a non-compaction cardiomyopathy, which is a failure of lamination of the endocardium during development. And these people have these trabecular recesses where clots can form. They're at high risk for not only having systolic dysfunction and arrhythmias, but also can have thromboembolic events and strokes related to that. So it is a high-risk disease, presents early on in life and many times. And if you just were to give bubbles at a very low MI, you actually have trouble seeing those trabecular recesses, because not only do you see the bubbles in the blood pool, but you also see them in the trabecular recesses and in the myocardium. But at a slightly higher MI, you have sufficient bubble destruction within the capillary bed, but you don't have that same destruction, or at least you have replenishment of the microbubbles that are attached to the blood pool, and that allows you to have effective tissue contrast and effective contrast to reveal these trabecular recesses when they're present. Now, there are a couple of techniques that are really important to understand, and this is one of the reasons why if we take a regular ultrasound image and turn down the MI, that is not the same as doing a dedicated contrast imaging technique. And that is because there are several techniques that have been developed to be able to suppress the signal from the myocardium even further. So one is this technique called pulse inversion, and this is where two pulses are sent out simultaneously, but in one of them is the inverse of the other. And so if you add them together, they produce no signal. And in myocardium, which largely behaves linearly, those signals cancel out. And so you basically get no signal from the myocardium, but you do from the blood pool where the ultrasound contrast performs nonlinearly. And that allows you to have a pure signal and effective contrast generation. Now, another technique also exists called power modulation, also sometimes called amplitude modulation. In this particular case, there are two pulses that are sent out. One is a full amplitude pulse, and one is a half amplitude pulse. The half amplitude pulse is doubled when it is received, and ultimately the two are subtracted. And if the two are, if the signal is linear, then in fact you have a full pulse minus a full pulse, and you get no signal whatsoever. Whereas if you have a nonlinear pulse, and when you double it, you don't completely eliminate that pulse. You're going to ultimately have a signal that's essentially representative of just the microbubble signal. So I love this slide, but dilution is the solution to pollution is something I learned on my surgery rotation, and I've used it all throughout, but I think it also applies here. And so what we do in this particular case is we often will draw up the bubbles. And in this case, I'm showing Lumason, but we will show you the other techniques as well in just a bit. But we, under aseptic technique, we inject the saline, 5 mL of saline into the vial. We reconstitute it, and then we draw it up with an additional 5 mL of saline for a total of 10 milliliters. And then we hand mix that, gently hand mix this, and then we bolus it into an IV. And generally speaking, there are way more microbubbles than you actually need for imaging. And if you inject the whole vial, you are going to be in trouble. And that's because you're going to get a lot of imaging right at the apex of the ventricle, but not much in terms of the base of the ventricle. So we bolus with about a half an ml to 1 ml of diluted agent every 10 seconds. And you can change this depending on what you see in terms of the myocardium. If you don't see it filling very well, inject more. If you see it, that it's causing a lot of acoustic shadowing, inject less. And we can chase that with a slow saline flush. And a key is really, really slow, 10 to 20 seconds, even slower, in fact, if you have a central line, because the agent gets to the heart quite a bit faster. And generally speaking, we would say start with a small dose, increase if you need it. You don't want to use too much of the dose if you need to. And it's always easier to give more. It's harder to try to break up the signal once it's already in the circulation. Try to activate or resuspend it within a minute of use, but if it's lingering for greater than 5 minutes, these bubbles actually come out of a suspension. It's an emulsion, and so you want to avoid them settling, so you really do have to resuspend it gently with your hand. For exercise, we recommend giving the dose about 15 to 30 seconds before the termination of exercise and start acquiring the images when the RVE opacified. And what that gives you is really this nice image of the initial perfusion of the left ventricle, which is really gives you critical information on perfusion status as well as masses, etc. You want to adjust the focus on the base in general, unless you're interested in apical pathology, in which case the scan line density can be improved by moving it to the apex. The challenge with the bolus is that there's a potential for attenuation, and it's really impossible to achieve a steady state for perfusion. So if you want to do a perfusion imaging, which is one of the goals of this technology, you really can't do that if you're having a large washout period. So you want to really be able to use infusions. And so infusions are great. You can turn them up or turn them down and titrate it to the appearance of the LV. You can get to a steady state before you start to do your contrast perfusion imaging. But the challenge, of course, is if you leave these for long enough, the microbubbles will come out of solution. So you do need to consistently rotate and resuspend them. And you have to use special tubing to be able to make sure you're not destroying the microbubbles as you're inserting them into the IP. Now, there are some things that can happen. You can, as I mentioned or alluded to earlier, you can give a large bolus of these bubbles, and it can go to the apex and cause shadowing of the base of the left ventricle. If that's the case, you can set the focus on your adjustable focus on the base. You can inject slower or at lower doses. If you can have blooming, just like with Doppler, you can have a large or rapid injection that causes the spread of contrast signals beyond its origin. And again, if you see the same thing, inject slower, lower doses. Now, the opposite is swirling, and this is not the same as spontaneous echo contrast, which is rouleau formation or inflammation. This is caused by excessive bubble destruction in the near field because your MI is too high, your frame rate's too high, or you're using insufficient microbubbles to be able to fill the left ventricle because you have a large left ventricle or otherwise. So depending on what the issue is, you could either decrease your MI, increase the amount of contrast, or move the focus to the apex. Now, I want to talk about its use within the United States. In general, we know that UEAs are underutilized relative to need. And this is from a paper that we published looking at about 100,000 patients over 18 years at our medical center. And if you just look at the blue here, that tells you the probability of contrast proceed. And while that's great, and it sounds like it's very promising, and we might congratulate ourselves to say we're doing really well, we're using contrast quite a bit more, that only tells you part of the story. Because if you look at the red, that's the likelihood of encountering a patient with suboptimal image quality. It turns out the rates of suboptimal image quality have increased over the years faster than our rate of use of contrast. And that's because we're using echo in a broader population. We're using it amongst patients who are more obese than they were beforehand, and we're also using it in patients with new indications and patients in the ICU, et cetera, which may not have great imaging. So overall, about 2.6% of the echoes receive contrast, whereas about 10 to 20% of patients overall in multiple studies have suboptimal image quality. And that's not something that's related to the sonographer. It has to do with the patient health. Use was proportionally greater amongst inpatients, as you might not be surprised by if you use contrast, and that's because IVs in general are already in place in inpatients, not only because the inpatients may have poor image quality, but also because they also have IVs already and it's easier to give. And so at the encouragement of Steve Feinstein, who had seen this graph beforehand, and said, you really need to update your slides. We went ahead and updated our slides, and now you can see that we really use ultrasound enhancing agents in about sort of 30 to 40% of our studies, and it's really matched the use of suboptimal image quality. But lest you think this is just an issue of the Beth Israel, and you don't want to go get your care there, I'm going to show you the rest of the country and what it looks like. And this is data on 11 million adults receiving echo and about 745,000 receiving stress echo across 2,400 sites in the U.S. And on the left here, you can see the use of transthoracic imaging, on the right of stress echo imaging. And on the top panel, you can see in the blue, the darker blue, indicating that there's more volume. So you can see Texas, New York, Florida doing a lot of echoes. But if you look at the bottom here, you can see that as a proportion of the number of echoes they do, Minnesota actually leads the way. And in fact, Texas and Florida and New York are actually not doing as much contrast imaging as they possibly could. And ultrasound enhancing agents overall were used in about 6.8% of outpatient transthoracic echoes and about 21% of stress echoes. So certainly less than that 10 to 20% that we think is needed. And what's more, if you look across states, as I alluded to, you can see a massive difference by state. With Minnesota, 20% utilization, 20% of the echoes in Minnesota get contrast versus 1.1% of those in Delaware. And you might say, well, Minnesota individuals are not the same as Delaware individuals. And so we looked at that. And one thing that's been consistent across studies is that in general, females receive contrast at a lower rate than males do. And that is true even adjusting for suboptimal image quality. Why that is, it's not clear, but it may have to do with overall disparities in females getting as intensive care as males do overall. But it is certainly something that has come up again and again in multiple studies. Older individuals get contrast more, and those who are have more comorbidities also get contrast more. But even if you adjust for all those, and you adjust for site level characteristics, such as sites that use contrast happen to be more frequently large, rural, nonprofits, and teaching facilities, there's still a 4.4-fold difference in use by site. And that really speaks to the need for better standardization for use across the United States. And so ASE, American Society of Echocardiography, came out with a survey as part of its ASE Trend Survey to ask the public and those who perform echo whether or not they find or what they find to be the most difficult in terms of the overall study, thinking that we've added on all these different things to our exam. It could be longer studies, expanded protocols, a lot of patients that we see. But actually, the number one thing was technically difficult patients due to body habitus. You know, patients are becoming more obese, and as part of that, it's more and more challenging to actually get good quality imaging. So then when you ask, in our opinion, what are the main barriers preventing your lab or institution from using it more appropriately? And the number one thing is it's too much effort to administer. And the number two is that sonographers aren't trained in the use or administration of contrast. So if you're watching this, kudos to you, because at the end of the day, you have taken a major step to be able to educate yourself and empower yourself to be able to use contrast. And that's a really important part of this. And when we ask what would be the main driver to appropriately use contrast, number one on the list is ability for sonographers to insert IVs, which we're going to go over. And I think that's a really essential part. And I'll get to that in just a bit. Number two is the ability for sonographers to inject contrast. And I just want everybody to know here that as far as we know, there is no state law that specifically prohibits sonographers from being able to inject contrast. Moreover, it is within the scope of practice from the SDMS and the American Society of Echocardiography. And so this is a very useful test, and it is absolutely appropriate for sonographers to be able to give contrast within a modern setting. And we have a multi-societal consensus statement that we recently published, which I'll allude to as part of this talk, that ultimately goes over what those safe injection practices are. When you ask people what are the two care settings where you think that UEAs are most underutilized, the number one thing is the hospital outpatient setting. And that's because people don't have IVs. And so at our center, for the longest period of time, we would wait for 45 minutes to be able to get an IV nurse to come up and place an IV. Well, 45 minutes out of an hour-long exam, really a 45-minute exam, means that in general, by the time you finally get the IV in, you've forgotten about the contrast itself. And so people move on and they don't use contrast. And so there's a real role for trying to train sonographers on IV placement. And that's because these really barriers start very early. So I could survey 227 program directors from the JRC DMS, and only 18% offered any IVs insertion training, and only 5% certified sonographers on IVs. When you ask people why don't they have contrast in the curriculum, the number one reason was that current educators don't have sufficient expertise. And so we're in a recurring cycle where educators don't know how to place IVs or give contrast, and as a result, they can't train the next generation, and it becomes a perpetual cycle. So we're trying to break that right now. We're doing training with you to be able to do IVs and be able to administer contrast, and we hope that this will empower you to be able to go back to your facilities and say that you have the skills necessary to be able to administer contrast. In contrast to that, our MRI and CT technologists all leave school with training, and so this is something that we really need to improve upon in terms of the wheelhouse of sonography. Now, there are lots of benefits for use, and I'll briefly touch on these. We know that in general, the contrast volumes are larger and are more similar to that of cardiac MRI. We know that because of that, we get more accurate estimation of our left ventricular ejection fraction, more similar to the gold standard of cardiac MRI, and less inter-observer variability. Regional wall motion is improved. In fact, we know that in general, regional wall motion assessment has only moderate inter-rater agreement on unenhanced imaging. And so this really helps in a very difficult place to be able to improve our understanding and appreciation for regional wall motion abnormality. And that's true at stress as it is in rest as well. You can use it to look at vascular and avascular structures, as my colleague Dr. Wilson has alluded to, that occurs well outside of the heart. But of course, you can also use that same kind of technique to look at intracardiac masses as well, to see if it really is dark and black, in which case it may be a thrombus, or has some degree of uptake, in which case myxoma and other sort of lesions may be on your differential, or very avid uptake, in which case you may have to worry about a malignancy. Apical abnormalities are shown to be improved with the use of contrast. It helps identify people with apical hypertrophic cardiomyopathy, particularly those with an apical aneurysm or apical thrombus. We know that people who have apical HCM and have an aneurysm are at higher risk of not only thromboembolism, but also arrhythmia. So this influences their management. They get ICDs, implantable defibrillators. Left atrial appendage on TEE. TEE imaging is a little bit tricky because of the high frequency, and so there's a lot of bubble destruction. You have to turn down your MI very, very, very low. But in general, it can help improve confidence for thrombus exclusion prior to cardioversion. And in one small study, actually was associated with a reduction in embolic event. Of course, you can use this for stress and just to improve the images themselves, and it improves accuracy, reproducibility, and reader confidence. It also can help with lower downstream testing and cost if you get the right diagnosis up front. We could also, as I alluded to earlier, can use microbubbles to be able to assess whether or not there's perfusion defects. And so when we looked at this with inotropic stress, with dobutamine, it improved coronary disease detection versus wall motion analysis alone, helps define the extent of wall motion, and improves upon wall motion analysis in identifying people at risk for death and MI. Across the pond in Europe, they use quite a bit of high-dose adenosine for vasodilator perfusion imaging. And in that particular case, it has equivalent specificity and higher sensitivity than the gold standard of SPECT, and enhanced prognostic value versus SPECT. In left bundle branch block and non-ischemic wall motion abnormalities, these really tough cases, it improves the detection of ischemia versus SPECT. And you can also do this quantitatively and actually measure the amount of uptakes. And that can be done, and when it's done, it has a sensitivity and specificity of greater than 80% versus the gold standard of angiography, and superior prognostic information for qualitative data alone. So I want to show you how this plays out in practice. And this is a particular study from the Houston Methodist Hospital and Bill Zogby's group, 632 patients receiving contrast. And all the red here you can see are suboptimal images. The yellow is uninterpretable. So a full quarter of the patients in the surgical ICU had uninterpretable images. This is after the contrast. And you can see a striking difference, even just looking at the color alone. You can see that uninterpretable studies occurred in less than 1%. And in fact, technically difficult studies occurred in less than a quarter. So this is really, really a helpful tool to improve image quality. But of course, I already told you that. But this group took it one step further, or two steps further, and suggested that, in fact, by using contrast, it actually helped avoid further diagnostics in up to a third and the majority of patients in the surgical ICU. It changed management in 2/3 of the patients in the surgical ICU, including procedures avoided and medications or procedural changes that were there. And as a result, this was highly cost effective. So if you take a look at the cost of the contrast in $2008 and subtract the cost of the avoided procedures, you can see that there was a net savings overall of about $77,000, which is about $122 per patient. So this is a really effective tool, and this study has been repeated several times, and I'll show you some of that data. This is data from Ontario on the left, and you can see it's probably similar to the US as well, but you can see that the rate of echocardiography in the red has been increasing over time, but the rate of repeat echocardiography has been disproportionately increasing. And that's because we have a trust issue. What happens if an echo is done in an outside hospital and you don't have access to the images? Well, oftentimes we just repeat the echocardiogram. And so we need to improve the ability to be able to have the right diagnosis up front so that we improve the ability for us to trust each other. Piedmont Hospital in Lynn is a very high user of contrast, and they studied this looking at routine use of contrast in the first heart failure mission and found that there was a 90% reduction in unjustified repeat echocardiography and an associated reduction in length of stay by about a half a day, which is around $700 savings, as well as a 20% lower risk of a prolonged hospital stay defined as greater than 5 days. We looked at this in our JACC Imaging article as well, in patients recently admitted for hospitalized for acute MI. Of those who got an echo within 60 days of discharge, contrast use was associated with a lower rate of cardiac non-stress imaging, numerically lower rates of cardiac catheterization. There were no differences in readmission rates, days alive at home, or cost, although if you actually look at the numbers, the group that got contrast, in fact, had lower costs by about $1,000 on average. So there are 4 overriding practices that heavily influence contrast use. One is a standing order for contrast administration. And at our center, we used to, before we moved to Epic, have an order that said you can use, we order an echo as with or without contrast. Now we moved to Epic, and since that time, what we have is the sonographers put in a preliminary order for the contrast at the time when they make the decision to give, and then that is co-signed by the physician of the day. Sonographers enabled to make the decision and administer a contrast. This is absolutely huge, and it's probably the most important thing you can do. And at the end of the day, we got around this in our institution by saying that ophthalmologic techs had a precedent in which they were giving timolol eye drops under supervision. And so we said, if we can set up a program where there's appropriate supervision and training, then ultimately this is within the scope of practice of sonographers to do, and that's exactly what we've done, and that's exactly how we've been able to achieve the contrast rate that we've been able to achieve. And sonographers trained and placed, enabled to place IV. So this is something we're doing today, but also something we do regularly with our sonographer staff. We bring them up to the cath lab and they practice placing IVs. We bought an arm off of Amazon, a plastic arm, and they practice with that. And then we have them practice and do IVs. And it really is a skill that you can learn. And then lastly is the presence of a physician and sonographer advocate. And I'm very, very lucky to have Jessica Stout as our technical director for the lab, who is an absolutely fabulous sonographer and advocate for contrast use. And so we rowed the same boat at the end of the day. So we can really present that to our staff and our faculty, saying these are missed opportunities where contrast could have been used but wasn't. So lastly, I just want to talk a little bit about safety. We are a non-invasive cardiology lab. We're not used to doing invasive procedures, or certainly things that carry risks. And at our medical center, 1 floor up is our cath lab. They take risks all the time. But the important thing is that the benefit to the patient is maximized and the risks are minimized. And that's really what we want in medicine. So just like any other medication, it has side effects. Allergic reactions or anaphylactoid reactions, which are due to a complement activation, can occur, but rarely in about 1 in 15,000 cases. And these can happen in somebody's first exposure to the agent, so it doesn't require any prior exposure, so it's a little bit different than the typical type 1 hypersensitivity reaction that we might see in anaphylaxis. And so as a result, the ISC's policy is that all labs have to have a policy for early identification and rapid response to severe responses, and that means everybody in your lab should be trained. They should know how to respond, and they should know who to call in those cases. Allergy kits should be available, accessible. This is a picture of our allergy kit. We have a saline bag, pressure tubing, an EpiPen, and also antihistamines in there. And in fact, actually, if you break up in a code cart, your code cart has epinephrine, but it has epinephrine at a dose of 1 in 1,000 versus this, which is a dose of 1 in 10,000. In fact, a dose of 1 in 1,000 can cause ischemia in some of our patients, whereas a dose of 1 in 10,000 really shouldn't cause ischemia in those individuals. Most of these occur within 30 minutes of use, and so I tell people to turn on the lights if the patient's complaining and look at their chest, look at the back, see if they have a rash, and then see if they're complaining of anything, see if they have wheezing or throat tightness, and call somebody. A low incidence of temporary back pain is possible, thought to be due to retention of the microbubbles in the glomerular capillaries. And so dilution actually can help potentially reduce this. The other things that if the patient does have it, you can treat it with a warm patch on the back, and you can ultimately give them, I've heard anecdotally at least that you can take the ultrasound probe at a high MI and put it on the back to be able to break up the microbubbles. I don't have data to show that, but I've heard it said beforehand. I don't mean to scare anybody, because I do think it's important to contextualize this in what we do within medicine. And this is a great paper from Kevin Way and colleagues looking at the relative safety of different agents. And in fact, we can see that even with low osmolar iodinated contrast agents, the risk of a life-threatening reaction is substantially higher than that of ultrasound enhancing agents. These are amongst the safest of contrast media, but the small risk does require vigilance and preparedness. And this has been studied again and again and again. So, and in particular, these are all the studies that have been published on the topic pre-2020. And you can see here, Mike Main, one of my colleagues, published really a seminal study on this, 4.3 million patients from the Premier data set, looking at those who were inpatient and got contrast versus didn't get contrast. And in fact, there was no increased risk of death within 48 hours of receipt. In fact, if you adjusted for somebody's likelihood of getting contrast based on their clinical conditions, they were actually less likely to die. And that's going to come up again, so just pay attention to that fact. So what do we do to prepare yourself? Train your staff, train your staff, train your staff. Leverage the unique resources you have. ICUS is a great website. It has a number of really great resources available, both from a safety standpoint, but also protocols, etc. You can ask your clinical application specialist as well. They have a lot of wealth of information. They know if a hospital in your area might be doing the very thing that you're looking to do. Teach through example, and then have the staff repeat back those protocols so you can ensure that they understand it. And then don't just stop there, reassess and reassess their competency. Plan for the local response to the event, the when, the how, and the who. So when we started a clinic in Lexington, we didn't start by giving contrast. We started by meeting with the nurses in the area and saying, what's going to happen? Who's going to respond in the case of a contrast event? And what happens if the person who's responding is away or unavailable? So having that plan in place and really clearly spelled out is going to make you prepared so that when something, or if something does happen, you'll be prepared. And if you do enough contrast, we do about 30,000 echoes a year, you can imagine that you're going to have reactions occur. So you have to be prepared. Have the allergy kits available and stocked, and then track issues. Retain the vial, report the event details, and document the reaction. This is now part of the AAC adult, the recently released adult echo reporting guidelines released by the American Society of Echo. You should retain the vial, report that to the company, and the company ultimately has the responsibility to report that to the FDA as part of their pharmacovigilance group. And then I think really importantly, debriefing on ways to improve afterwards is really helpful. Both meeting as a group, because this can be jarring from an emotional standpoint if you're not used to dealing with events, but also thinking about what went well, what didn't go well, and how we can improve on the process. And this is what we have in our lab on the right here. And you can see that we have this in really every single machine and all the labs where we use contrast. And so what happens is if there is a suspected reaction, our fellows carry a bubble pager, and they're told that this is like a STEMI. If they get a page from a sonographer, they have to drop everything and run to go respond, because we really want to be able to support our sonographers and not suffer in silence. The one thing that does and should change how we practice is really our preparedness. And so this is a multi-societal guideline we put together, endorsed by 14 different cardiac societies, including AAC, British Society of Echo, Canadian Society of Echo, the Society for Diagnostic Medical Sonography, AIUM, SBU, and many others. And then we also looked to see, has the safety profile really changed over time? So we looked at this particular issue in a nationwide analysis where we looked at patients receiving transthoracic or stress echocardiography and who got contrast and didn't get contrast to see whether or not they were at risk within the 2 days after receiving the contrast. 11.4 million adults across the US, 2018 to 2022. And we compared those who got contrast versus those who didn't. And we adjusted or propensity score match for those with similar characteristics to be able to essentially get an apples to apples comparison. And then we looked at how that changed across years of the study and across ages. And here you can see how we got patients into the study. You can see ultimately that we propensity matched them and then compared those groups. And I want you to draw your attention to the right side here of this study, which is the matched cohort. And that's the one that are similar characteristics of their patients. And you can see that at the end of the day, the rate of death was extremely low. And in fact, actually was lower in people that got contrast than those who didn't get contrast. And in fact, the rates of anaphylaxis, MI, VT, cardiac arrest were all pretty low and similar, and if anything, a little bit less than those who received no contrast. And so you can see, in fact, that the patient mortality rate within this group was substantially lower in those who got contrast. And that was true across the board, whether or not you were using Lumason, Definity, or Optison, you had a lower risk within 48 hours, regardless of brand. And that was true also across years of study. So while we think that COVID might have had an effect on the overall allergic reactions, minor allergic reactions that are reported, there was no increased risk of death that we observed across the Asians across years of study. Mortality within 2 days was lower in those receiving contrast, and there was no statistically different significant differences in non-death outcome. And so this supports the continued use of contrast, but also vigilance and preparedness, because if you are the patient who has an event, you want to be with a team that's adequately prepared to be able to respond. And I'll leave you with this one quote, which is, we think about what we do, but not necessarily about what we don't do. And it's really important to understand that diagnostic errors are a big problem. And this is a report from the National Academy of Medicine suggesting that postmortem examination research spanning decades has shown that diagnostic errors contribute to approximately 10% of all patient deaths. It's a massive amount. It's about $300 billion in costs per year. And so if we have a tool at our disposal that's going to help us get better information in a timely fashion and ultimately reduce the chance of error, why aren't we using this? And so I'll leave you with that thought is, what's the harm of not using microbubbles, and can we do better? Thank you very much.
Hello, my name is Jess Bout. I am the Technical Director of Non-Invasive Cardiology at Beth Israel Deaconess Medical Center in Boston. I am here today to talk a little bit about contrast administration in the Echo Lab. Here are my disclosures. Before I talk about the administration, I always like to just refer back to the ASC guidelines for everyone's reference and remind our sonographers that are listening that the use of contrast is integrated into our guidelines. And there's an antiquated way of thinking, I think, for sonographers that we should only be using contrast when we can't see 2 or more segments. And that was kind of ingrained in us as sonographers for a really long time. And really, this has evolved so much, and there's so many more practical applications now for our contrast use. And it's very important for use in our patient where we need a good assessment of left ventricular ejection fraction, those patients that are getting cardiotoxic chemotherapy, patients that are getting considered for ICDs, patients anytime where we need a good evaluation of LVEF or of regional wall motion abnormality. Even in good quality images, the contrast use is imperative. We know that there are a lot of consequences to our suboptimal images: misdiagnosis, low diagnostic confidence, the need for downstream testing and additional imaging, and of course, inter and intra observer variability. And there's a lot of issues that we run into as sonographers that impede our imaging: body habitus, obesity, lung disease, a lot of these things that we see in the ICU on patients that really need the answer the most. And so contrast use in the patients is imperative. And I always like to say, contrast use should never be looked at as a crutch. It's not a deficiency of our skills. It's something that should be used as a standard to give our patients the highest quality of care. So some goals in our contrast imaging: we want clear demarcation of our endocardial borders. We want a homogeneous fill of the LV, the apex to fill without swirling, consistent resonation from the base to the apex, and a limit artifacts. And this is accomplished differently by patient, by pathology. A dilated LV, an akinetic apex, a slow heart rate will all impact how we have to administer the contrast. We also want to remember that we don't want to bolus a whole amount of contrast at once. We look at safety and we look at the possibility of reactions. And although it's very low, we also know that there is a correlation between the amount of contrast we're giving and the likelihood of a reaction. The dilution, a nice slow push can reduce the rate and the likelihood of a reaction. So image optimization, a few things that we want to look at. Just like in our 2D echo, we would never do a full echo and never consider our 2D settings, right? So just like in 2D, there are settings that you want to look at. You want to pay attention to how you're dosing and administering based on the patient and the pathology, and also some other things that we can do as a sonographer that will help our examination. Standard approach typically is to administer 1 cc of contrast over about 10 seconds. But again, that will differ based on the situation. The biggest settings that has the most impact on our images is our mechanical index, or MI. This is most of our standard presets are set for the very low MI imaging. We really want the lowest MI that still gives us sufficient penetration. And again, this will vary based on machine, based on preset, And that's why we also have our amazing clinical apps specialists that can come in and help you with your presets to make sure that they're adjusted appropriately. So in this patient here, the only thing I'm changing in these 3 images side by side is the MI. I'm not changing anything else. And you can see that if the MI is too high, we have some destruction of bubbles in the apex causing that twirling. So we can't really visualize the true apex. Whereas all the way to the right, I've decreased the MI to the appropriate level, and you can now see filling all the way to the apex. A couple other things that we can look at that can help our image quality. One of them is persistence. Persistence is essentially the smoothness of the image. So as I increase the persistence on my machine, you get a little bit of that smoother image. And dynamic range is essentially the grayscale. So it controls the shades of gray on our image. So a higher dynamic range displays more shades of gray, and that lower dynamic range is going to be a higher contrast, sharper image that pulls out some of those gray tones. And then finally, our overall gain. You want that gain to be set appropriately so that you can see the contrast and it's not too high, not too low. Our color maps can be a useful tool sometimes to see the difference, the different walls. I have found that with some machines, there are some color maps that look good with the contrast, depending on the version. So that's one thing that can help optimize your image. But when looking at artifacts and how to fix them when we're administrating, swirling is probably the biggest thing that we see. And it's really caused by too little contrast or the contrast injected too slowly. This happens a lot in our poor LV function or if the MI is too high. So to correct this, you're going to inject more faster or decrease the MI. I have this example side by side of 2 ventricles. Both of these ventricles require contrast, but for different reasons. So the image on the left requires contrast because we have an akinetic apex and we want to rule out a thrombus. The image on the right, we just don't have good image quality and we cannot rule out regional wall motion abnormalities. But if I inject at the same rate and the same amount for both of these patients, I'm going to get 2 very different images. If I inject at a standard rate, the image on the left, I'll get a ton of swirling in that apex and it won't fill all the way. Whereas the image on the right, because it's the normal size ventricle, that was sufficient for that image. So if you do have a dilated LV or an aneurysmal apex, it is important to push a little bit more and a little bit faster. And this is just one further example of this. This is a huge dilated LV here, and the image in the middle was the initial push, and then when we pushed a little bit more, it did go all the way to the apex. Sometimes it's helpful if you're really having a hard time filling that apex. If you follow with a big push of saline, that can help. I also find that sometimes just having a patient take a breath in helps fill that apex. And just as a side note for this case, that ventricle was so big, it wouldn't even fit in the sector. So we went and did a short axis view to really show the extent of that thrombus in the short axis view with the contrast as well. Your focus position should typically be at the level of the annulus. However, if you are trying to look at the apex and look at a thrombus, sometimes it's helpful to pull the focus position up towards the apex, and that helps fill in a little bit. The following is a case of that. Here we have our apical 4-chamber view in our 2D. And then our 3-chamber view here. And our initial administration of contrast, this was an incredibly difficult patient, but you can see how there's so much swirling in that apex. I can't see the true apex. I can't visualize that aneurysm. And it's really, really difficult to see. So we had to push a little bit more and we had to follow it with a significant amount of saline in order to get that apex to fill. And then when we did so, you can see how now we can really see that apex. And you can see how it's akinetic and you actually have a little maybe dyskinetic segment all the way at the top there. The second artifact we see quite often is attenuation. And this happens when we push too fast or we push too much. And you get kind of that attenuation in the basal segments there. So you can see it a very little bit on the left, but on the image on the right, you can really see that you're getting it all the way kind of almost into the mid-ventricle. This can actually be really helpful if you're trying to visualize the apex, right? If you want to give a good push just to see the apex, that's great. But if you're looking for a uniform view to look at the walls, you want to make sure that you don't have this attenuation. To get rid of it, you can just give it time. You can increase the MI, or you could do a flash. But ultimately, you want to decrease the dose and that injection rate when you're seeing this. From a sonographer perspective, a breath hold can make a big difference in our imaging. Breath holds can really help reduce the artifact and improve the delineation of our endocardial borders. The only change in this image side by side here is the breath hold, and you can see how much better it looks with that breath hold. And finally, just some other troubleshooting tips here. Always check your IV before you inject. If you go to inject and you hit resistance and you're pushing and pushing and you're hitting resistance, you are destroying the bubbles in your syringe. So before you do anything, flush your IV, make sure it's patent and that you're not getting any sort of resistance. Also, if your extension tubing is really long or is like really longer, thicker, you might need to flush with saline to push it through. Make sure you don't have an IV filter on and make sure you're mixing per your manufacturer's instructions. And just a few other tips from a sonographer perspective with a couple of case examples. Always avoid foreshortening, go off axis, and do apical sweeps in the event of an apical aneurysm. This is a case study of a 78-year-old male who presented with shortness of breath with known CAD. We have our parasternal long axis here and our apical four-chamber here. And the first thing I notice on this image is how rounded this apex is and how that apex is kind of coming in towards the transducer. So when you have that rounded apex, you really need to consider that you're probably foreshortened. And you can really see this nicely with the contrast as well. The contrast really does a nice job here showing the walls, but are we really showing all of the walls? Well, no, because we are so foreshortened, we're not seeing the true apex. And again, that rounding of the apex really gives it away. Now, when we go down a rib space, we're able to see all the way to that true apex and actually see a small aneurysm there in the apex. If we look at this side by side, you can really appreciate how much of a difference this is between the images. My final case study here is regarding foreshortening again. So this is a 57-year-old female that's presenting with dyspnea and thoracic chest pain. And our initial image here, you can see we have a four-chamber. The apex is incredibly difficult to see in this image anyway. It does look a little bit rounded, but with the contrast administration, you can see that the apex is indeed akinetic, but it is very rounded in this image. As soon as we go down a rib space, you can see that we have identified here an apical clot, which will obviously change management significantly for this patient, as they'll now be put on anticoagulation. So that completes this section on administration of our contrast. Thank you so much. Next, we're going to review some fundamentals of placing a peripheral IV. As we know, contrast is not widely used because of workflow barriers, one of which is obtaining NID. So this is an excellent skill set for our sonographers to have, and it will reduce workflow barriers when using contrast in our labs. So I'm going to turn it over to Christine, who is going to go over how to place the IV.
Okay, so first we're going to review the components needed before you start your IV and IV setup. So on the table beside me here, we have in orange a tourniquet, we have Tegaderm, we have the IV needle, in this case the butterfly needle, we have alcohol glove, and then we have gloves. So the first thing you want to do is make sure that you wash your hands before every IV start, and then you want to don your glove. Make sure the patient's arm is resting and in a comfortable position. And then you want to take the tourniquet and then apply the tourniquet just above the vein of intract. Usually we're using the antecubital vein, as these are big veins and suitable for contrast imaging. You want to palpate the skin, looking for the right rays of the vein. You want a vein that's soft and compressible, and you want to make sure there's not too many valves within that vein. So here, you can see that there's a good vein, although it's on an angle. We're going to take our IV kit, open the IV, just prime our butterfly needle. We want to make sure we remove the plastic cap. And then when we insert the IV, we want to make sure we insert it in line with the vein. Prior to insertion of the IVs, we're going to make sure the area is clean. Use an alcohol swab and swab from the inside out. Now placing again the butterfly needle in line with the vein, we want to angle. We want to make sure that the bevel of the IV is facing upwards. We want to angle the IV on a 15 to 20 degree angle at first insertion. Insert it into the vein. Lower the needle parallel to the skin in the vein, and then guide the catheter in along the needle. We want to remove the needle and the capping, and then the only thing that is left into the skin, you'll see flashback from the needle, the only thing that is actually left in the vein is the small catheter. You want to clamp the IV once it's in. Okay, and then remove the tourniquet. Now with the patient in a resting position, you want to take your tegaderm, making sure the area is clean. Open the tegaderm up, remembering to keep it sterile. Slide the backing off of the tegaderm. You don't want to touch the surface, but you want to keep it sterile. And you want to use this to position and hold the IV with the plastic tubing coming from the, in this case, the corner, where there's a slit designed for the plastic tubing, and then you want to remove the tape. And then your IV is ready to go. Prior to injecting contrast through the IV, you want to make sure that you flush the line. Usually we do this using a 10 cc saline flush. Make sure the air is out of the saline flush. Take the small protective capping off the IV. Insert and twist the saline flush, dual lock syringe into the IV. Open the lock. Withdraw, and you'll see some blood coming back into the tube. And then you want to feel as you flush the line, and you can feel it going in smoothly into the IV. Close the clamp on the IV, and then you're ready to go and hook up your contrast setup. So now we're going to talk a little bit about how to remove the IV. So you can see here our IV setup is complete. The clamp is closed. We're going to start by taking off the tegaderm. Sometimes we put a finger on the IV so we don't pull it out rapidly, and we're just going to remove the tegaderm slowly around the IV. Being careful not to touch the tubing into the skin. We fold the IV, then we take a small gauze, place it on top of the IV, and withdraw. Then we take the tape, and we're going to put it on top of the gauze. You can ask the patient to bend their arm or hold pressure for at least 2 to 5 minutes.
We are going to review now the preparation for Optisond. I have removed the Optisond from the refrigerator, and I'm going to agitate it by just slowly mixing it between my hands here. And the goal is to get it a nice milky white. And once it's that nice milky white color, I know it's correctly mixed. Now, there's two methods that you can use to administer the contrast for cardiology. So the first is a direct bolus method. And for this one, we're just going to take an empty syringe and withdraw the contents of the Optisond vial and then inject it directly. We do have a vent spike here that is available from the manufacturer. This spike, not only does it simultaneously spike, but then you could also pull out the contents as well with it. The other alternative for this is if you had a needle, you could also just use a standard needle to vent it and then use a second one to withdraw it as well. But we have 2-in-1 here, so we're just going to use it for this demonstration. I'm going to remove the blue cap from the vial and just do a quick swipe with an alcohol wipe here. Now I'm going to remove the little bottom here from the vent spike and then just directly put it in and then remove the blue top here. And this is where I put my empty syringe. Gonna flip it right upside down here and then withdraw the contents of the vial. Now the Optisond is ready to go. I'm going to just remove any extra air here. And make sure to put it on clamps. And we're just going to inject, for this method, 1 cc over about 10 seconds. And of course, this changes depending on the patient and depending on the pathology in question. Now that's the first method, the direct bolus method. The second method is the dilution method. The nice thing about the dilution method is it gives us a little bit more product to use. And like we've talked about with SACI, we do think that dilution helps reduce the amount of adverse events. So we always encourage dilution. So again, I'm going to take my Optisond out of the refrigerator. I have a 10 cc syringe filled with my saline, and then again, I have my same vent spike. Just like before, I don't have that nice milky white yet, so I have to agitate it. I'm going to just flip it upside down and go right between my hands here for a few seconds. Right. And I need 3 cc's of saline in the syringe. That means I have 7 extra. So we talked a little bit earlier about making sure the IV is patent before you do anything and before you inject your contrast. So we can use the 7 cc's to actually check our IV and make sure it's working correctly. And then that leaves us our 3 cc's. Right. So I'm going to, again, stick that vent spike straight in onto the blue caps. This time, again, I have my 3 cc's of saline in here. But just like before, I'm going to draw this back, but now I'll have 6 total. Going to invert it, make sure it's mixed within here. And now this time we're going to administer 2 cc's over 10 seconds. And again, depending on the patient and the pathology in question. We're going to review the preparation of Lumaton. Lumaton can be delivered in two ways. It can be delivered with just the psych and the vial of Lumaton, and you can also get it in a pack with the Lumason and a 5cc saline syringe. So 2 methods that we can use Lumason. I'm going to start with using the 5cc syringe that comes in the packet here. So this packet comes with the vent spike, the Lumason, and then also the 5cc's. So we're just going to put this little syringe together just by twisting here. And then you want to remove the top as well. Then you're going to remove the blue top of the Lumason. And finally, open up your vial site here. All right. So you're just going to insert this right into the spike here, and you should hear it click in once it's in properly. And then we're going to open up the green top and twist on the 5cc syringe. And now you're just going to inject the 5cc's right in to the vial. And from here, we're going to hand agitate it vigorously for several seconds. And the goal is to get that white powder off of the bottom and have a nice homogeneous mixture that's milky white. Can't mix it too much. So I have found that there's no residual white powder on the bottom. So I feel like this is mixed well. So I'm just going to flip it upside down and pull back the contents of the vial. And this is now ready to be administered. The second way is a diluted method. So the diluted method, I'm going to use my own 10cc syringe, and then the Lumason, and then again, the vent spike here. So for this one, we're going to, just like before, inject the 5cc's. So we're going to pull it back to the 5cc's that are in the syringe, making 10cc's total. One thing you want to be really careful of here, since you do have 10cc's in the syringe, you want to make sure you don't put any more than 5 into the vial because that will destroy bubbles. I'm going to put this on here, twist it on, flip it, or actually, before I do that, I'm going to inject my 5cc. And again, making sure not to go any more than that. Just like before, shake vigorously and make sure you get all the white powder off of the bottom. And then once you confirm that you have it mixed well, you're just going to pull it back into the remaining 5cc's that are still left in your syringe. Now, because we cooked some from the vial and we had some here, we want to now just invert this a few times and make sure it's well mixed here as well. And that is ready to inject. Now, regardless if you do the bolus method here or the 10cc dilution method, you're still going to start with about 1 cc injection over 10 seconds. And of course, just confirm based on your patients, based on your images, if you need to inject faster or more product. All right, so next we're going to review the preparation for DEFINITY. The unique thing about DEFINITY is that we are going to mechanically agitate using the vial mix. There's 2 methods of administration. We can do the direct bolus method, or more commonly, the dilution method. We'll start with the direct bolus method. So we're going to open up our vial mix, push the lever over, and insert the vial. So at the top, and it automatically sets for 45 seconds.
The Vialmix is a mechanical agitator. It has an automatic 45-second activation cycle. You want to ensure that once the Vialmix is started, you do not interrupt the cycle or lift the cover. Mechanical agitation allows for a consistent size and distribution of microbubbles, stabilizing them in solution. From extensive experience, we find the Vialmix easy to use, and it lasts for many years through multiple series of bubble activations.
Great. One complete, we remove the vial. And we can see that it's a nice homogeneous milky white now, and it's well mixed. So for the direct bolus method, we're going to uncap the DEFINITY, wipe it once with an alcohol wipe here. We always need to vent it first to reduce that negative pressure, make sure we're not destroying bubbles. So I'm just going to vent it with a needle here and stick a needle into the top. And then with my other syringe, I'm just going to directly pull back to DEFINITY from the vial. You just go right in the center and then pull back the volume here. Now with the direct injection method, we only need 0.1 to 0.2 injected at a time. We'll wipe our IV here. And then we're going to inject slowly at 0.1 to 0.2. And we are going to follow it with a saline flush. Maybe easier to do this with a 3-way stopcock, so you don't have to on-click one before it's in the other one. But if not, you can always just rotate them. Okay, so the more common method that most of us use in cardiac is the bolus method. So same thing, I'm going to mechanically agitate my DEFINITY. All right, now that's complete. We'll just flip that up and remove that. And again, you have that nice milky white now. Remove that cap. Now, same thing applies. We do need to vent it. So we're going to stick that needle in to the side to vent it. Now, I have a 10 cc syringe now. We have to waste 1.3 mils because that's the amount of DEFINITY that we have. And then, so I should have the 8.7 less. And now I can pull back the rest of the DEFINITY that's in the vial. Now, once that is complete, I'm going to just hand agitate that to make sure it's nicely mixed within the syringe. And then we're ready to inject. And this time, we're going to inject about 1 ml over 10 seconds.
No, I really appreciate everybody for attending, and I just wanted to point out that this is a wonderful webinar. There's lots of important topics being covered, and hopefully we can address any questions that might come up amongst the broader group. So feel free to put your questions in the Q&A box, and we will try to address them on the spot. So starting out, there's some questions about what kind of a gauge needle is ideal for contrast injection, and after injecting, do you have to flush? So Jess, you're the master, having just shown us how to do it. Do you want to take this one?
Yeah, sure. Can you hear me okay?
Yeah.
Okay, great. So we typically use 22s for the standard patient. For the flush, that's a great question, and it really varies by institution. I think when a lot of our apps specialists would say, flush after. If you're using a diluted method, I don't think it's as important as if you're using a bolus method. I don't tend to flush after unless I have I'm having a hard time getting the ventricle filled. If I really need to get the apex filled more and I have an akinetic apex, then I'll use some saline to flush it through. But I don't think it's a requirement by any means, particularly when we're diluting our agents.
Yeah, I mean, I think the dilution is really where the value is here, because you just get so many microbubbles within each aliquot of contrast that really are more than you actually per se need. And if you were to give that all in one bolus, there are sort of several things that can happen. One is you can get a lot of contrast signal at the apex with essentially a ton of attenuation at the base, and so you lose the ability to be able to see parts of the wall. But you can also you're also giving essentially a drug at a very high dose and a very high dose concentration. So we know that back pain, for instance, may be less common in people for whom there's been it's diluted, and that the side effect profile may have something to do with the peak dose concentration. So giving it over time, giving it diluted, can sometimes be very helpful. And there are some indications where if you're giving it through in somebody who's undergoing stress and you're giving a bolus, and you want to get those images right away, where that might help to have a flush in particular. But there's no requirement, but it is recommended that some dilution happen.
Yeah, and I just want to clear up one thing that I said when I was watching myself, the recording, which is really embarrassing. But I said to inject generally 1 mil over 1 minute, really 1 mil over 10 seconds is what I meant, and I misspoke, and I apologize. So you don't want to bolus a whole bunch, but I find that you really don't need much contrast here for our patients, so for the typical patient anyway. So really just starting with one slow push, 1 cc is really enough to start.
Yeah, go low, start low and go slow. If you need more, you could always give more. So lots of really good questions coming in the chat here now. Things about OB indications, placental perfusion, fetal perfusion, fetal echo. All really, really good questions. There's not as much data, I should say, in this population. In particular, there's off-label use for obstetric indications, but there are a number of case reports that have been out there using contrast in pregnant women that have not suggested a particular risk, although we don't have any, there are a few studies, but we don't have very sort of large-scale studies in this particular area. And so the theoretical concern is that you have a big clump of contrast that doesn't break up and could occlude the placental vascular bed, and therefore cause sort of fetal or placental ischemia. And the reality of the situation is that there's the placental capillary bed and the vascular bed in general is so vast, and these agents don't tend to clump, and so you really don't have much of a risk for that. But in terms of perfusion and fetal echo, I think I'm going to defer to some of my pediatric echocardiography colleagues there, but I don't believe there's a lot of data in that particular area. Real good question that somebody had is how do you convince your management to allow sonographers to place IVs? So Jess, you've been working on national efforts with Intellios and others to create IV certification, and of course you did this locally at Beth Israel. What would your thoughts be on how to convince management?
Yeah, I think for a lot of us that are getting resistance, the best thing you can do is model it after other areas of your hospital. So I think if you look, you will find that there's other departments, particularly radiology, where non-nursing staff is placing IVs. And so a lot of the work that Jordy and I did integrating contrast use here, a lot of our policies and procedures, we took a lot of that directly from radiology because it was already done. And I think that's really valuable because you can show administration that this is already established within your hospital. So go and look at your MRI, your stress tests. I mean, there's your CT, and there's a lot of areas where they're already utilizing IVs. But really, it's about creating policies, outlining competencies and training, and then outlining how you're going to remain competent. And I think IGIS has some really great resources on how to do this on their website as well. And I do have to say, I think the hardest part when you're initiating a training for IV is the redundancy and having your sonographers just do it all, over and over again, because that's the only way to learn, right? And when we initially started this, we had our sonographers just go up to the cath lab for a day and follow along there. And they did several IVs and it was great, but then, you put them into real life practice and then you kind of struggle and you don't have, necessarily support there. So what we started to do was kind of buddy them up one-on-one with a sonographer that was skilled in IV to make sure they had the support for those tougher sticks and to kind of reinforce those skills at the time. So I think that's really helped as well.
Yeah, and I want to reiterate that this is not there's no contraindication to sonographers being able to place IVs. In fact, if anything, it's the opposite. The SDMS and the ASC both, and of course ICIS, very much support the role of sonographers as placing IVs within the scope of practice. And I think that's reflected by the updated national education curriculum, which came out through the CAHAP, which really reflects the expanded role for sonographers to place IVs. So IV placement is really a local decision rather than a national decision. Nationally, the skills are there. It's certainly within your wheelhouse to be able to do. You want to get the training on it, and that's why you're all here. But once you get that training, it's about trying to go back to the institution and say, there's precedence in other areas. There may be other professions that are inserting IVs. MRI and CT technologists routinely get IV training as part of their education. Yet, as sonographers, only about 18% of schools offer any kind of IV training, and certainly less than that certify sonographers in placement of IVs. And so we leave school without the ability to be able to do that. So it's reliant on your job or your other ways to be able to pick up on those skills. So what I would say is, familiarize yourself with your own particular medical center's ability and sessions. Get the didactic education here and elsewhere. Come to meetings. Grab if you want. Get an arm. You can get them for pretty cheap off of Amazon, and you can practice doing IVs. And the more you do, the better you get. So that's a great question. So there's some questions about contraindications, and contraindications about Optison, and I think we can sort of talk about more generally. In general, these are good questions, but they're important ones to look at. It's important to know the indications and contraindications to your agents overall. And so looking at the label, understanding what those contraindications are. And in general, it's people who have allergies to components of the actual agent. So if you happen to have an allergy to, for example, polyethylene glycol, which is a component of, or PEG, which is a component of Lumason or Definity, you may want to reach for an agent that is non-pegylated in that particular setting. If you have an allergy to perfluorine gas, you may want to go for an agent that doesn't have perfluorine gas. If you have a contraindication, one thing to be aware, particularly with Optison, is that because it's albumin, some people who may be Jehovah's Witnesses or otherwise can't receive blood products, that's a consideration in receiving those agents as well. But it's specific to the patient in front of you. So if they've ever had a reaction, or if they to that particular contrast agent, or they have a known reaction, a severe allergic reaction to a component of that agent, then it is contraindicated. But by and large, I think it's really important also to say that these are some of the safest of all contrast media. And so in general, these are really good agents. They don't seem to cross the placental barrier. I know that was another question that was raised in the chat. And they allow us to be able to get a better visualization of the cardiac function and structure. So moving on what's the recommended dosage for visualizing the left atrial appendage to rule out thrombus during a TEE, and any tips or tricks for optimizing settings? Yeah, really good question. Very tough setting. Using the TE can sometimes be challenging because the frequency is higher, and we know that the resonant frequency of a microbubble is inversely related to its frequency. So as your frequency moves up from 3 to 5 megahertz to maybe 5 to 7 megahertz when you're dealing with a TEE, the resonant frequency of the microbubbles moves down, and so you may not be able to get as good of a sort of resonant imaging. The other part of this is that you can destroy microbubbles quite a bit more easily with a higher frequency, and so you may need to either give more microbubbles, or oftentimes we'll just turn down the MI as much as we can. And I think it's helpful to know what the structure looks like before contrast, and then as you're giving the contrast, and wait the time out to make sure to see it sort of all come into the space. Turning MI down manually, even if it's down a lot, can sometimes really help with this, particularly when you're dealing with DE. But it's a little bit of a work in progress, shall we say.
I wanted to comment on the question here. Do you ever inject into PICC lines or portacaps? Because this actually recently came up at our institution. So, when in doubt, I say if you're not sure, absolutely always loop in your nursing. Portacaps are tough because they, for here anyway, like you need a physician's order to even access it. And then there's certain things that you have to do post administration. You're worried about infection. You're worried about, a lot of things with that port, and you want to maintain the integrity of the port. So we always, if we have no other option and their port is already accessed and we have to utilize it, we absolutely pull in nursing and get nursing approval and make sure that they are involved in the entire process. PICC lines are okay, but the portacaps are the ones that tend to be problematic. So I would definitely use those with caution.
Yeah. So a lot of questions about sort of the ideal settings and to optimize contrast for a bubble study. And I want to say, really look at the ICUS website. There's some fabulous, because optimizing your bubble depends on both your machine, but also the bubble, but also the application you're using it for and the particular patient you have. So for example, you can have really, for thin patients, there's not a lot of harmonic energy near the skin. So if you're doing harmonics, you may not be able to see things that are sort of closer to the skin as easily. If you have a big person, you may need to to have better sort of depth of penetration, may need to sort of increase the MI slightly to be able to sort of get better penetration. And so there's a little bit of a wiggle room around this, but as a starting point, the ICUS guidelines on this are really, as well as the ASE guidelines, are really good in terms of helping to define sort of the equipment settings. And one important thing to remember is that when you're doing a contrast study, the out-of-the-box LVO setting you get is not necessarily the one that you always want to use for contrast imaging. And so get your app specialist in to go set Tokalat devices, have them help you set the create presets that may optimize the contrast settings. And oftentimes that's a fundamental low MI sequence with multipulse cancellation, which is built into the device. And when you are doing your out-of-the-box LVO setting, that might, for example, be a second harmonic imaging at an MI of around sort of 0.3, and that might be fine for LVO. But if you're trying to look at perfusion or other sort of details, you really need to have a lower MI, so you're not destroying the microbubbles that are in the individual capillary beds within the myocardium, but also that can help you keep those bubbles around for a longer period of time. So really good question, but it's going to depend a little bit on your patient and as well as on the type of device you have. So work with your manufacturers to try to find out what works best for you.
Jordy, there's a few questions about what's in the allergy kit and about people that are using rapid response versus allergy kits. I'll say from my perspective, we do keep allergy kits in all of our lab, just because it's good practice to have something accessible immediately if you are having like a real severe anaphylactic reaction. We actually are in the process of kind of revamping our allergy kits a lot. We kind of looked at it and decided there's a lot of extra things in there that were kind of beyond the scope of for us of what we would do in immediate capacity. And so we kind of parted down, and now we just have an EpiPen, PO Benadryl, IV Benadryl, and I think that's, oh, we have atropine in case of hypotension. I think that's it, right, Jordy?
Yeah, we have the saline start kit has sort of pressure tubing and
Yeah.
everything that you would need, a bag of saline that you would need to be able. So the key components when you're dealing with a upfront reaction is early on epinephrine, EpiPen specifically, because the epinephrine that you get within the code card can be 1 in 1,000, and that which you get in EpiPen is 1 in 10,000. The doses at 1 in 10,000 are not known to cause coronary ischemia. 1 in 1,000 can cause some vasoconstriction. So using, at the end of the day, getting epi into the system is more important than not getting epi into the system if you have somebody who's really truly crashing, regardless of the dose. But I think getting it at the correct dose is going to be the best. So if you have a 1 in 10,000 EpiPen, those are great to be able to use. I did want to sort of just clarify a comment I made earlier, because a number of people sort of commented in the chat that, so I didn't mean to imply that Optison, because it has albumin in the shell, is a contraindication to those who have a hypersensitivity to blood or blood products. It's very uncommon for that to actually occur. It's just more that if you have somebody who desires not to have human albumin or products made from potentially from blood products, that may be a consideration that you want to share with them as well. So, but it is a great great agent, as well as many of the others, to be able to really be able to pacify the heart and look at perfusion as well.
I want to address a couple of questions I've had, because I do think it's really important about if you have a patient that has a reaction. There's a few in here. How do you help the sonographer, overcome that fear going forward? Because it's very jarring when you have a true reaction, and it can be really scary for the sonographer. So I think it's really important first to kind of do a debrief about the event. So did everything happen the way you expected? Was there a response immediately? What was the sonographer supported in that moment, right? Because that's ultimately my biggest concern for our sonographers if we're injecting, is that we're fully supported if we do have something happen. And so that's the first thing. Is there anything that we could have done differently to maybe make this a more successful response next time, or was everything done well? The other thing is just to remember that contrast agents as a whole, and as Jordy kind of talked about earlier, they are so important for quality in our studies, and for diagnosis, and for management changes. And despite these reactions that are rare and scary, overall, it is an incredibly important diagnostic tool in our labs. And it really does. I could pull countless cases of just case studies of where we've, sent somebody to the cath lab, avoided a stress test, got people on embolics, looked at an apical HCM. There's so many instances where we're really identifying pathology and changing management for patients. So remembering that that's the overall goal, is to better the care, knowing that, there is a risk, but we should be properly have all the tools in order to handle that risk appropriately at our institutions.
Some questions about are contrast agents indicated in pediatric patients? And that's a really great question. I think, over the last couple of years, there's been an expanding indication for pediatrics, and now I believe there's an indication for all three agents now for use in pediatrics. I know there's certainly been changes in this for the last couple of years, and so I would check with the manufacturers in terms of what the recommended dose is for those individuals, and what the weight-based dosing is. Not a pediatrician myself, I don't want to steer you astray here, but I would check with your manufacturers about those questions. And so there's stacked it, and some questions about how common is an allergic reaction. Good question. We know that the sort of serious allergic reactions are exceedingly uncommon. So 1 in 10,000 to 1 in 15,000 range in multiple studies across multiple decades of use, and that really hasn't moved very much. The more common reactions can occur, but those are mostly sort of nuisance reactions, things like back pain, some degree of flushing. People can have vagal reactions on a timed occasion, but of course people can have a vagal reaction if you injected saline, and so that's not a true reaction to the agent as much as it is a reaction to the exposure or the experience of getting an IV and getting something injected into you. So that being said, I think the reactions are unpredictable, so you don't necessarily know when that's going to happen, and it could be somebody's first exposure to the agent. So this is not meant to be a fear-mongering by any stretch of the imagination. If anything, we can say that as a class, the agents are amongst the safest of all contrast media, period. And there's certainly higher risk that we take in other parts of the hospital and other things we do. So, but it's important to be prepared. And so for those circumstances where somebody walks in and you don't expect a contrast reaction, but there is one, you want to make sure that there's that people are ultimately aware of what the policy is in your lab, aware of how to respond to it, and then can respond accordingly and in a streamlined kind of way.
I want to respond to someone that commented very early on in the questions here as I'm going through. You should wear gloves to mix the agents. Yes, absolutely. Believe it or not, that segment of us mixing took probably too many tries, because as much as you're used to doing it in real life, it's hard to slow down and do step by step. So I think by the time I got one that I was happy with, the gloves had come off, and that was it. But yes, always wear gloves when you're mixing your agents and administering them.
Somebody commented about does your allergic reaction protocol include sonographer increasing the power and holding probe on the patient to pop the bubbles? No, I don't know that we have that as part of our protocol, but for a reaction, but we anecdotally have heard this from people that when they do have back pain, that putting a high MI transducer on the back can sometimes help alleviate the back pain a little bit faster. I don't have any hard data to be able to show you to say that that's true or not, but that's something that people have done, and certainly it's a strategy when you're with a patient who's having back pain, and something that you can do. If you'd like to comment on how a well-run echo lab with contrast can generate revenue and streamline workflows as well as a benefit for patients. Yeah, really great question. I think this is something that we alluded to a little bit beforehand, but in general, we duplicate a lot of efforts in echo, and we do a lot of repeat studies, and the rate of repeat studies, at least based on some data from Canada, it seems to be increasing faster than the rate of echocardiography as a whole. And so getting the right answer the first time and finding things is really helpful. And I'll give you another sense of this. This just happened the other day when I was reading in a lab with Jess. And that we saw a patient that had really pretty good pictures. You imagine they're otherwise we wouldn't necessarily reach for contrast at the start, but because of our experiences, we use a lot of contrast in our lab, and we did use the sonographer did use contrast in this particular case, and nicely illustrated that patient had an apical aneurysm that we wouldn't actually have known about had we not used the contrast. So I think that my take on this is use the tools you have at your disposal to make the best diagnosis up front. And I always, when I read cardiac MRIs with our fellows, and somebody's had an echo beforehand, particularly when the indication is things like evaluate for LV thrombus, I said, did they have an echo with contrast? Because that's in many cases a missed opportunity where there was an opportunity at the site to be able to at least do a good evaluation, and hopefully one that's a definitive evaluation up front. So we know that contrast use has a downstream ramifications. About $122 saved per patient used is the number we hold up. That's from a study in 2009, and that it doesn't increase long-term it doesn't increase workload, but actually can help decrease your the amount of procedures you do, as well as sort of imaging you do in sort of cascade testing. So really a benefit. And I think in getting to the point of how do you convince your administrators to adopt this, I think one of the best things to do is to show them what an echo looks like. Or an ultrasound looks like, because sometimes the administrators may have read lots of echo reports in their time, but may not have actually seen what an echo looks like, and the challenges we have with our image quality and the challenges we have in getting to the right diagnosis. And then you can show them the echo with contrast, and it's like a light bulb. It really helps you address that.
I think we're almost at time, Jordy. I just want to address one last question here. Is there a contraindication for PFO? No, and actually when the FDA first put the black box warning on in 2007, they specifically did some studies with patients in PFOs and did not find any adverse events. And if we think about it, there's potentially a quarter of us walking around with PFOs right now. So that's not a contraindication, and that was pulled back many years ago as part of the contraindications. So as it stands for all of our agents, the contraindications remain any known allergy to the agent or any of its components.
Yeah, this is similar to the OB question earlier, in that the theoretical concern is a big clump of contrast goes through the PFO or a shunt and occludes a vascular bed. But again, that's very unlikely to happen in practice. When it's been used in these types of patients, doesn't happen. And so no contraindication. I would say if you have a patient with a PFO and they have a filter on their IV, take out the filter before you give the contrast, because otherwise you're not going to get much of a contrast signal. So make sure you're just not injecting through that PFO filter.
Introducing the future of cardiovascular ultrasound, the new AccuSun Origin ultrasound system. Engineered to meet today's imaging challenges, this brand new cutting-edge echocardiography platform combines best-in-class technology with powerful AI-supported applications. AccuSun Origin launches and measures over 60 ASC guidelines spectral Doppler values. With best-in-class image quality, the AccuSun Origin is the first system bringing contrast-enhanced strain imaging and analysis. This advanced technique can assist the clinician in the early detection of myocardial damage. It allows clinicians to monitor myocardial function over time in patients with hypertensive heart disease, congestive heart failure, and cardiotoxicity from chemotherapy agents. With just a touch of a button, launch AI Assist, 2D Heart AI, or any of the other 5,600 plus AI-powered measurements. Continuing decades of leadership in image innovation, superb image quality delivers superior clinical data acquisition in every scan. Featuring walk-up usability, the system is intuitive and quick to learn. Its ergonomic console reduces repetitive motion and risk of strain by the operator. AccuSun Origin is a complete cardiovascular solution for transthoracic, intracardiac, and TEE with vascular access capabilities. Let's explore how to perform a contrast echocardiography study. Press the Contrast Enhanced Ultrasound button to start your contrast study. When the CEUS control is pressed, the MI is significantly lowered to reduce the destruction of contrast. Note that AccuSun Origin users have found that the focal zone on the left of the screen is best placed at the basal to mid-LV. The system offers a flash option. This option allows the user to temporarily increase MI to reduce contrast saturation. Let's look at a case study. A 55-year-old female presented to an outpatient lab for evaluation for mitral valve regurgitation after referral from a heart failure clinic. A transthoracic echo and TE for evaluation for transcatheter edge-to-edge repair or TEER was ordered. The patient's medical history included spontaneous dissection of the LAD, status post-percutaneous coronary intervention or PCI, status post-AICD, hypertension, functional, MR, shortness of breath. The patient was at high risk for mitral valve surgery. Note the left ventricular opacification of the 4-chamber, 2-chamber, and 3-chamber views with endocardial border delineation. Performing 2D heart AI on this exam, the AccuSun Origin provides a single-click analysis of endocardial speckle tracking, which is sensitive to the regional wall motion abnormalities, as seen here in the segmental bull's-eye map and global longitudinal strain results. Note the correlation between the overall ejection fraction and global longitudinal strain between the AccuSun Origin's LVO2D heart analysis, with an EF of 40% and GLS of -12.6, and 4D heart analysis, with an EF of 39% and a GLS of -11.5. With the AI-powered strain analysis capabilities on board the system, clinician efficiency is supported by reproducible GLS in technically difficult, contrast-required exams. The one-click GLS functionality on the AccuSun Origin with deep learning AI that provides auto-apical view recognition quantifies strain in just 15 seconds, with or without contrast. No ECG needed. AI can also assist in handling poor windows. It was designed for accuracy in challenging scans or in patients with irregular rhythms and detects LV volumes with an accuracy of 99%. The AI-supported tools on the system were shown to deliver high accuracy in view classification across multiple sonographers. AccuSun Origin is the only system on the market that can deliver accurate, reproducible strain with the use of contrast. It's a leap forward in cardiac assessment made possible by intelligent design.
We're excited to have you with us today. We're going to describe how to do an ultrasound enhancing agent study on the GE9-5. First of all, what we're going to do is position our patient. We'll get that done. Sir, would you please lay on your left-hand side with your left arm above your head? Thank you. The next thing that we do is we're going to go to our preset on the GE9-5, and we're going to look at our parameters and get our preset set to start our imaging. The first thing that we're going to look at is our MI, mechanical index. That's our power on our system. Ultrasound enhancing agents are imaged on a very low MI, so we're going to adjust that to start with. We start off in the apical position. The other thing that we're going to look at is our frequency. We want to have the correct frequency for the patients that we're imaging based on their characteristics and size. Then we're going to be able to look at our compression. Compression is a parameter that makes our image look good, but it does not affect the working power of our bubbles. In other words, it does not disrupt the bubbles. Same thing with 2D gain. We will adjust those according to the needs with our patient. Also, we're going to look at our pulse repetition frequency correct for ultrasound imaging agents. And then the next settings we're going to look at is DDP, which is persistence, and then UD clarity, which is our speckle reduction parameters for our studies. Once those are set, you're ready to image. So we're ready to give the patient our product. You're going to give the ultrasound enhancing agent at a very slow rate for your patients that have normal ejection fractions. However, if you have a patient that has a lower ejection fraction or has a larger volume overloaded ventricle, you would want to give more product a little bit quicker in order to get the quality of images you're looking for. We start with the 4-chamber view, and then we will begin our study. Now, when we first get our pictures, we start in the apical position. When you get your image, you want to take a moment and fine-tune your picture. Even though you've done starting settings, every patient is different. For instance, we may need to adjust the MI up or down depending on the patient, their size, and what we're seeing. If we don't see the basilar area of the image, we may need to increase our mechanical index to make that happen. Same thing with your compression. You might want to alter your DDP, which is your persistence. Do you want a smoother image or a more contrasting looking image, depending on your needs in your lab? And then also we want to look at our number of cycles. On a UEA, ultrasound enhancing image agent, we particularly want to increase that so that we get a good amount of pictures within our video clips. Other things that you might need to look at when you're doing a study or things you may come across, maybe some troubleshooting. Suppose that you're looking at your picture and you get attenuation. That's where the product is all up at the apex of the heart. To overcome that, you can do a couple of things. You can either freeze your image and wait for a few moments, or just watch the image. The product will eventually opacify the entire ventricle and fill in your picture. So time is your friend with attenuation. If you have swirling, that can happen from a couple of different things as well. Your mechanical index may be too high and you're causing the bubbles to disrupt. Or potentially, if the patient has a lower ejection fraction and the ventricle doesn't help you with getting your images clearly, you might want to inject some more product at a faster rate in order to make those pictures look as you need them to look. Some other things that you may encounter when you're doing an ultrasound enhancing image on a patient is maybe the product is not coming into the heart as clearly or as quickly as you want it to come in. There are some things that we can do to make that better. For instance, if the product is injected in the arm, you can raise the patient's arm, and that will open up the valves in the vein and will let the product come in and fill inside the ventricle. You could potentially have the patient do a quick sniff through their nose, which also brings the product in for you to be able to see it. So that covers the ultrasound enhancement agent settings that we do on the E95 system. If you think this images look really good, wait till you see the new GE Pioneer system. Thank you for being with us today.